question and then the correct answer.
A capillary blood sample from a finger stick for glucose testing must be used immediately.
Immediately. A. Yep. Number 2.
In an emergency situation, all of the above. Don't read them.
Nope, it is all of the above. That is the correct answer.
When opening a new bottle of glucose control material, label the bottle as followed EXP and a 90-day from the date opened expiration date.
That is correct. Did I say that enough times? Do you mind doing number 4, please?
Okay, so the following information is entered into the physician XC Prometer when the test strip barcode is scanned. And I put A, the test strip lot number, but I think the answer is E, all of the
The
above.
answer is E, all of the above. Yep, thanks. All right, number 5.
Reasons the patient data not found message displayed on the monitor may be due to all of the above.
All of the above. Yep. Number 6.
The following statements are true regarding glucose exceed pro test strips. All of the above.
All of the above. Complex test writing here, guys. All right.
A bottle of control solution is opened on May 23rd, 2014. This control solution expires B 90 days after the control bottle is opened unless the manufacturer's expiration date occurs sooner than 90 days after.
Yes, ma'am. Number 8.
The Precision XC Prometer will be inoperable unless the meter is docked every 24 hours.
24 hours is correct. All right, number 9.
When an incorrect visit number is scanned and the glucose result is transmitted to the wrong patient medical record, the operator must contact the POCT coordinator or the clinical laboratory shift supervisor.
That is true. Number 10.
If glucose meter result is less than 50 or greater than 450, less than 45 or greater than 250 for NICU and level 1 or 3, the requirement is to verify the result by sending a sample to the clinical laboratory for glucose testing. True.
That is true. All right, each one of those is worth 10 points. So give yourself a score on page 1, 10 times however many you got right. If you got anything less than an 80, we'll need to talk about that later. So if you did not get an 80 or above, just hang out afterwards and we'll talk about what you missed, and then we'll remediate by taking another test. Not a huge deal, okay? If you guys don't mind filling out, there's a competency that looks like this that should be stapled in front of your test. Just make sure that you filled out the employee name and the signature part of that. And then before you guys leave, I will sign everybody's as the evaluator. Don't tear it off the packet, just keep it with the packet, because all of these things will go, besides the green sheet and the evaluation, will go to your unit educator. Okay, sorry, I probably should have said that first. All right, Nikki lady, thank you very much, good luck to you. They don't tie up their babies very much upstairs, so. Any questions about glucometers before we move on to restraints? All right. So everybody's favorite topic, restraints, and this is the last thing we're going to cover, guys, so hang in there with me. One of the national patient safety goals a couple years ago is to identify patient safety risks inherent in the institution's patient population. That is in addition to other things talking about suicide identification, suicide risk. So we do screen patients for being a suicide risk during their admission assessment. Review the policy and procedures for assessment and care of suicidal patients. There's a specific policy that deals with that situation. If a patient does verbalize that they are suicidal and or they have a plan, we need to notify the physician, and then they need constant observation, okay? Constant observation for suicide is considered a behavioral restraint, and so would require following the behavioral restraint policy. This, yeah, so you'll need to get that order. Sorry, I'll get back to that. So we really do try to use restraints as a last resort. We have a number of other items that we will use to avoid restraining people. So what are some low-level interventions? You'll often hear them called low-level interventions or restraint avoidance. What are some things that you guys have seen in other facilities? What's that? Sitter, yep, we can use sitters, absolutely. What else? Oh,
The posy wraps,
so posy wrap,
like the
like
strap.
this? No? Like a
Yeah, more
seatbelt
like
kind of
a
thing?
seatbelt, yeah.
Yeah, unless it's to help them with positioning, that would be considered a restraint, actually. We do have a couple of things, distraction. We have these activity belts.
Oh my god.
They're really awesome. And who's my ACEs people? You guys stock these up on your unit. For ACEs is our elderly unit or Jerry unit. So for folks who just have some little extra energy in their fingers and don't know what to do with it, you can give them washcloths to fold, or you can give them these things, which are awesome. Buttons, zippers, lots of textures and things, just some place to put their energy besides pulling out picks and NG tubes and stuff like that. Why not? You guys can play around with some of this stuff, right? All right. This is called an activity belt. Even if your unit does not stock it in the clean utility room, you can get it with an order, you can put in an order to Central Supply without a physician order. None of these things requires physician orders, okay? So that's the activity belt. The next thing is relocation, right? If you're worried about your patient pulling stuff out, sometimes if we can just have eyes on, move them to a bed closer to the nurse's station, or even in a chair out to the nurse's station, just something to, and that goes with distraction as well. Give them some place to put their attention. We do have safety mitts. You might hear some people call them boxing gloves. The official name is Freedom Splint. Safety mitts. These go on like a boxing glove and then Velcro around the wrist. This is not a restraint. This is not considered a restraint. As long as the patient still has access to his or her body, can still itch his nose. That's kind of the guideline that I look at. It falls apart later in my illustration, but for now, let's just go with it. So they can still itch their nose, right? So it's not a restraint because it's not tied to the bed. They have nice Velcro closures so you can still access their fingers. They can be on continuous pulse ox with this, no problem. You can do your CMS checks, get vital signs, whatever else you need to do. Just realize a highly determined patient will get out of this, okay? They will bite it off, put it in their armpit, put it in their butt. These ends get very, very gross, so just approach your patient with caution. These are single-use disposable items. If it's gross, don't try to clean it, just throw it out and start over, okay? Lots of units stock these, but again, this does not require a physician order. You can put in an order down to CS and they will send you some safety mitts. There you go. All right, the last device we have is called a Freedom Splint, and this can go both ways. So it just depends on how it's being used. If you have a patient with full mobility on both sides of their body, and you put this on one arm, this is not considered a restraint. All right, it needs to go over the elbow so that they can't, there's like little beanbag filling in it. This is so, I need to put this on the list of things to order. Theoretically, it will keep them from bending their arms. It's great to keep people from reaching over and grabbing picks, reaching up and grabbing NG tubes, if they're constantly going for it with one arm, okay? The other thing is, for some patients, it's just, it's better out of sight, out of mind. So say their pick is on the right arm, and just putting that on there so they can't see it and they can't really get to it, that is also effective. Now, again, this is not considered a restraint. I have 2 working arms and somebody puts this on one of my arms. If I have 2 working arms and they put it on both of my arms, now that's a restraint because I can't get to my face, right? I can't itch my nose. If I just have one on, I can still, access with that arm. If I have had a stroke, or if I'm an amputee and you put it on my one working arm, that's considered a restraint and would require a physician order, okay? Again, these are used, and I've seen these used in every area in the hospital. other than maybe the mom baby units. And they're pretty effective at keeping people from pulling stuff out. They're not great at protecting Foley's because the patient's arms can still kind of get down in this area, okay? So it just depends on what the use is. But again, it can go both ways. So if you have 2 working arms and you put it on 1 arm, that is not a restraint. It does not require a physician order. If you put it on both working arms, or if they only have 1 working arm, and you put it on that arm, then it is considered a restraint and would require a physician order. All right. So as an RN, you can initiate restraints emergently, notify the physician, and then they need to put it in order, okay? An order has to be co-signed within 24 hours of applying restraints. There needs to be, yes ma'am.
So as far as the low-level interventions, like you're gonna document that you're putting a freedom splint on 1 arm, but it doesn't require the 15 5-minute checks, is that?
That is correct.
The difference, okay.
That is correct. And I believe in Epic, it's like a restraint avoidance, and you can document what you've done to avoid restraints. But there's not any specific charting required. Like say if I put safety bits on the patient, I don't really have to document that I've done that. Because it's not a restraint. There's an area for restraint avoidance, but you don't have to be specific about it. So for behavioral restraints, they're renewed. I have to read this because the policy is a little bit convoluted. So I do encourage you guys, all of our policies are excellent policies. As somebody new to an organization, I highly encourage you to review the restraint policy though. It's just so different and it's highly audited and just one of those things. The behavioral restraints, so either the suicide prevention or if a patient is a danger to self or danger to staff, those have to be renewed every 4 hours, okay? For acute med surg restraints, which is kind of like just for prevention of dislodgement of a medical device, those are actually good for 3 days, which is a little bit different from what you may have seen at other organizations. Someone within an hour of application, a trained person, and now this will be you after today, you guys need to do a face-to-face reassessment of the patient within 1 hour, okay? After that first hour, then documentation has to be done every 2 hours. We'll talk about that a little bit later. That whoever ordered the restraints or a member of that line of care has to reevaluate the patient every 24 hours. But the restraints don't need to be renewed except every 3 days, okay? Every 72 hours. All right. Restraint orders. The attending MD must be notified of restraint use. So when we say attending must be notified, that means you notified the first call, and the policy, or the way the process works is that then they are required to notify the attending, okay? PRN or restraint orders are never acceptable. We never had this issue, except now when you have the Q72 hours, every now and then you'll stumble across one that's been used as PRN. So just think about what your intent is. Obviously, we want to release the patient every 2 hours if it's safe to do so, to allow them to do range of, to help them with range of motion, toileting, stuff like that. If the intent is that they have met the behavioral goals and you're not going to put it back on, not going to put the restraints back on, then we need to discontinue that order in the computer. If the patient then requires it to be restrained at a later time, that's a new incident, okay, and requires a new order. Don't take it off and be like, yeah, the guy's totally behaving in like 6 hours, and the next shift later, they have to put it back on. They're like, oh yeah, I've got a restraint order. Like that's a PRN order, okay? So just make sure that your intent is matching what your orders are.
For the behavioral ones,
Yes.
are we the ones that reevaluate every 4 hours as well? We were saying that like within an hour we're the experts that come and reevaluate behavioral as well.
Behavioral's a little bit different because behavioral requires a renewal of the order every 4 hours,
Right.
but it doesn't require a face-to-face but every 24 hours. So you might be the one communicating with a physician that says, he's still aggressive and a risk to self and others, so we need these to continue. So you can be that person that's advocating for that.
Okay.
Yep.
And you're just calling every 4 hours?
Yep.
5 minutes?
Probably 5 minutes.
Okay.
Yeah, thank you. So the order, obviously the order has to be entered into the EMR. All right, so what do we, so we talked about kind of the restraint avoidance things. Now let's